And welcome back to the channel. I just wanted to give you guys an update quickly. We had a bit of technical difficulties in the Wi-Fi connection, but today's guest is Dr. Olarogun, and he hails from Nigeria, and he is a gynecologist, an obstetrician, and he was basically a fertility specialist or infertility specialist who works for the Heart Fertility Center in Cape Town. And today we speak about sex and reproduction. I hope you enjoy the episode. I'm not sure if I read correctly. The facility that you work for is also in Cape Town?
It is, yeah. So I'm based in Cape Town.
Okay, cool.
I work in a couple of practices. And the IVF unit I work with is actually in Christian Barnard Hospital in Cape Town.
Medcare. That's so nice. That's a beautiful hospital.
Yeah, no, it is rather,
How long have you been there?
So that clinic has been going since the hospital opened, since they moved it from old premises into the new premises. So we had the clinic before that, and then we have the clinic in there when they moved. So we've been there since over 4 years now, since they started. It's been there for a while.
Sorry, how long have you been a gynecologist for? And how did you get to being a gynecologist?
20 years, quite a while. I qualified in 2000, so about 20 years.
Oh, wow. And have you been practicing just in South Africa or any other countries?
We have a clinic in Namibia. So we are in Windhoek often, so we have an IVF clinic in Namibia. And I do lecture in Botswana as well. So I go out to Botswana and do a bit of teaching and stuff in Gaborone. And then obviously lectures and in parts of Nigeria sometimes.
All right, that's great. I like that you're practicing in Africa. You're adding back to Africa. I like that a lot. I'm
trying.
Thank you. Thank you very much.
Yeah.
And then I guess we can get right back into the first question then. If that's okay with you?
Okay, sure. Sounds good. Yeah, sounds good.
So research shows that there are like 237 reasons why people have sex, and that reproduction is only one of them. So what exactly, in a medical sense, is reproduction?
So reproduction is basically defined as ability to reproduce. In other words, for you to give birth or make siblings or make things that are close to you as much as possible. Obviously, that starts from plants right through to animals and then to humans. So as far as humans are concerned, it just defines the ability to make siblings or to make children or to make structures, if you like, that are similar to you one way or the other. So that's what reproduction is all about.
Right. Are there any limitations medically to reproduction? Obviously there's a physicality of reproduction, but are there any limitations medically?
So when you say limitations medically, are you talking about limitations that should be there, or things that prevent people from just reproducing?
That things that are just there, and then also things that prevent people from reproducing, like fertility.
Yeah, so I mean, look, obviously a lot of things need to come together for reproduction to happen. So there need to be male gametes, female gametes, they need to fertilize, they need to then start dividing and then implant into the uterus. That's the way the process is designed. So if there's anything wrong in any of those lines, then you have fertility problems, which is not, sort of getting pregnant. So you need those things to come together. The obvious thing is that if you're in a same-sex relationship, that doesn't happen, as human beings. So you need to have all those things together for it to happen. There are medical conditions, I guess, and the big one will be not necessarily a medical condition, but just a natural condition, which is age. So the big thing is that in women who get beyond the age of 42, 43, their eggs get to a point where they are just not compatible with making normal babies. So in other words, the eggs are older or older than they were at 35 or 30 or 25, for instance. And the competence of those eggs are a problem. So it's actually, I guess, nature's way of limiting women reproducing beyond a certain age. So the big one is that. In men, there are so many other reasons why men fertility issues happen. But as far as women are concerned, the one to really mention is the age factor. So once you get, and there's nothing we can do about that, once you get beyond a certain age, it becomes very difficult for those ovaries to be competent enough to make eggs that then, lead to formation of children, of offspring.
Okay, so you've mentioned and I mentioned fertility quite a bit. What is fertility and where does it fit in with reproduction?
So fertility and infertility go together. So we define fertility as the ability to conceive. In other words, ability for a woman to get a pregnant fetus growing inside her, or to get a fetus growing inside her uterus. That's, the raw sort of definition. And infertility is then defined as when that doesn't happen, when a couple have been together for 12 months or more. So if the couple have been together for 12 months having unprotected intercourse, and in that time they haven't conceived, then they are defined as having infertility. So inability to reproduce or inability to conceive. So basically fertility is just referring to the ability for conception to happen. But what we need to remember is that it takes two to play tango. So, in other words, a lot of times people always say, especially in Africa, there's always a feeling that it's all about the woman, and I guess the woman plays a big role, obviously, and there's so many places that things go wrong in a woman's system that prevents her from getting pregnant. And obviously she carries the pregnancy. That's what everybody sees as pregnancy and as delivery. But the reality is that in about 30 to 35% of cases, the fertility problem is with the man, which means that, that the sperms are either not enough, or he's not producing any at all, or he's producing defective sperm. So there's a number of reasons why that also happens. So fertility is actually not supposed to be looked at in just one unit of the woman. It's a unit of the husband and wife, or necessarily, so a man and a woman, not necessarily husband and wife, but man and a woman. So in other words, you need to look at fertility encompassing a couple rather than just one person.
I'm so glad you said. I'm so glad you said man and woman. That it's not just be looked at as a woman's fault or something. In that same sense, the same breath of reproductive organs in male and woman, is it possible for you to give me a brief description on the reproductive organs of a man and a woman?
Sure. Well, the easy one is to go straight to the woman. So I mentioned earlier that the conception happens and implantation happens in the uterus, which refers to the womb, which is the local term for the uterus. Attached to the uterus are little pipes called fallopian tubes, and next to those in the pelvis are the ovaries. And then in a normal situation, what happens is that the ovaries release eggs, which is called ovulation. And those eggs are picked up by the tubes, which is those little connecting pipes. And then the fertilization, which is the egg and the sperm meeting, usually happens in the tubes. And then when fertilization happens, they then travel from those tubes into the uterus and then implant in the uterus. So those are the functions of it. But the reproductive organs are essentially the uterus, the fallopian tubes, and the ovaries. But they sit in the pelvis. So if there's something wrong with the pelvis, that could affect the whole thing. Mm-hmm. For the male, it basically refers to the testes. Sperm production happens in the testes. of which a man should have two of them, that sits outside the body because the temperatures need to be cooler outside the body for normal function. So in utero, when the man is in the uterus of the mom, of his mom, the testes are actually still in the abdomen, and then they travel to sit outside in the scrotum, where normal function happens. And normal function does not happen when it sits in the abdomen. So in other words, if it doesn't come all the way down and it sits not in the scrotum but in the abdomen of the man, then it doesn't function normally because the temperature is not suitable. So outside there in the scrotum, temperature is suitable. And there's a whole process that goes on there in the testes to lead to formation of sperms. So from immature sperms to mature sperms. And then during the process of ejaculation, those sperms are then propelled through certain ducts, little pipes, into the urethra, which lies in the penis. And then that is ejaculated into the woman's sort of reproductive organs. So if there's anything wrong with any of that system that I've described, then you have a problem. So in other words, if you're not producing testes, if you're not producing sperms in the testes, we have a problem. Or there's an arrest in that whole cascade from immature to mature sperms, then there's an issue. It's been produced normally. The blockage in the ducts that propel it out into the urethra, then there's a problem as well. So those are all reproductive organs. It's the penis, is the urethra, which, and then the testes where the sperms are made.
Are they, obviously, men and women work very differently biologically. Are there anything specific to like African people from the continent, different countries, that can either like prohibit this fertility? Like, are there things specific to African people that prohibit them from falling pregnant or getting pregnant or things like that? Anything that we know?
Yeah, there is. I mean, I think depending on the causes of fertility or infertility rather around the world are the same. It's just that the incidence or how common certain conditions are vary from area to area. So incidence of things like endometriosis or polycystic ovarian syndrome would vary from certain parts of the world. I mean, you have it in all parts of the world, but, in Asia, for instance, you have more PCOS. In Africa, often the big problems are twofold. The one is fibroids, which are growths in the uterus, which we see a lot of in Black women. And unfortunately, it starts quite early and it's quite aggressive, and there's a lot of them, and it could distort the uterus, prevent implantation from happening, sometimes lead to miscarriages, but apart from the heavy bleeding and the pain and all that it causes. So it's a significant factor when we were talking about infertility in Black women. And the other big one is damage to the tubes. So I mentioned initially what the tubes are, and that is usually as a result of infection. So it's usually from sexually transmitted infection that may not have been picked up earlier on in the woman's sort of sexual debut or sexual career. So she might have had a number of partners beforehand, which one or two of them might have had an asymptomatic infection like chlamydia or gonorrhea that wasn't picked up, wasn't treated, and she's got exposed to that, and her tubes then affected. Causes of infertility in Africa would be tubal disease from infection that is not picked up, treated. So you have all that in Asia, in Europe, in America, but it's more of a problem in Africa than it is in those places. So, like I said, the causes are the same wherever you are, but they're just certain things that are more common in certain areas.
Okay. So I know that you defined infertility earlier on. I just wanted to know, are there any other reasons, like external factors that would cause infertility, like substances, medications, surgeries?
Yes. Yeah, so I mean, you know, if you've had surgery in your pelvis as a woman, for whatever reason, fibroids, for instance, or ectopic pregnancy, which is a form of pregnancy in the tube, but whatever kind of or endometriosis in the pelvis, if you've had surgery or you have conditions in the pelvis, that would affect chances of conceiving because it affects the function of those organs we described earlier.
Mm-hmm.
If you've also been exposed, and this applies to men and women, to chemotherapy or radiotherapy for childhood cancer or for cancer in the adolescent age, this chemotherapy and radiotherapy agents target rapidly multiplying cells. And those rapidly multiplying cells, unfortunately, include, you know, the cells in the testes and the ovary. So it tends to knock those out. So if you've had treatment for cancer in the early age, you might then become relatively infertile because the ovaries or the testes have been affected by those treatments. So those are external factors. The easier ones will be, or more common ones will be the use of things like smoking and alcohol, which is a bit difficult to define really because we all know that there are lots of people who drink a lot and still have multiple kids, or smoke, you know, tons and still have multiple kids. But the reality is that the more smoking that you do, the parameters we look at as far as semen is concerned is affected. And ovarian function is also affected by smoking. So even though it's more difficult to quantify, and it's not like 2 + 2 = 4. So in other words, it's not like the moment you smoke or start smoking, you're not going to conceive. It doesn't work that way. But we know that there is an element of affectation of those functions if you are a smoker or if you drink. And the same applies to the use of other substances. So we're talking about the use of maybe cocaine or other sort of recreational substances that people use. They all have some kind of effect on the function of the reproductive organs. So in other words, we always advise if people are trying to get pregnant to limit their drinking and try and stop smoking. So those are all factors that are easy to mention that one, you know, would be watching out for that could affect fertility.
All right, thank you. So in this big, I guess, world of fertility and infertility, are there any things we could do as men and women to, like, you know, help or prevent infertility? Are there things that we could do that could help us get pregnant or help us be fertile for longer or things like that?
Sure. Well, fertile for longer is tricky because, like I mentioned earlier, that's pretty much just age related. But what you can do is, and we see more and more of this, is to freeze one's eggs. Mm-hmm. So there's something called egg vitrification or egg freezing, which is available to young women, you know, who want to pursue their careers first and are not ready to start a family. And that's going to take a few years, and they know that at the end of that whole thing, they will be old to a point where fertility will become an issue. So we offer those women, you know, egg freezing and egg vitrification, where we stimulate the ovaries to make eggs, we take the eggs out, and then we freeze those eggs. And that could be frozen indefinitely. And those frozen eggs could then be used 10 or 15 years later, you know, much later, for, you know, to conceive, obviously within a limit, you know, because if the woman is 60 years old, she probably doesn't want to be getting pregnant at that point. But it allows you to push things out a little bit, at least gives that option to do that. And then the other things would be, so in the same line would be if a woman has a pathology that is already picked up in her younger years, like fibroids or endometriosis, then it's wise not to postpone pregnancy. Mm-hmm. So in other words, you know, if she's in a situation where she's deciding, I don't want to have kids now because of social circumstances, then she might be advised to try and have her kids early because it's going to be a problem later, because obviously the older the ovaries are, the more of a problem will be. And that applies to even women generally, even without those conditions. So you might just be thinking you're doing a PhD at that point, you're doing a master's, and you think, you know, and I'm at 35 or 36, I'm going to try and do it when I'm 39 or 40. The advice is not to do that. You know, just try and get the kids as soon as you can when those ovaries are still functioning. So that's age part of it. And then some of the things that we can do to try and keep our fertility going are those things that I mentioned earlier, which is, you know, the use of noxious substances. In other words, smoking, recreational drugs, and excessive alcohol usage. All those, you know, will be detrimental to the function of those organs we spoke about earlier. So one should limit those. So in a nutshell, we're talking about early start if one can. If you can't start early for whatever reason, think about freezing, you know, eggs that could be used later, or freezing embryos. Sometimes if you're in a relationship already and you just don't want to have kids yet, you can actually form embryos from the sperms and the eggs and freeze those as well. And then try and avoid noxious substances. And I guess the last point will be just a healthy lifestyle, you know. So, you know, vegetables, fruits, exercise, lots of sunlight, fresh air, and, you know, nuts, you know, all the sort of things that we all know is good, but it's always quite difficult for most of us to do them, you know, is what, you know, one should be doing. It not only helps with the general health of the patient, it also helps with the fertility potential of that person.
All right. So you kind of already like spoke about what can you do should you prolong like infertility, should you want to prevent infertility. So what happens when you are infertile? I mean, like what do you do if you want to reproduce? Like, are there options? Obviously, the eggs freezing, but anything else?
Yes. So that's the thing about that's what fertility clinics do. So you come in because you've been trying to conceive for over a year, or sometimes for shorter, depending on if there's been other things picked up, you know, in the woman or the man before that. And then we investigate. So what we do is try and find out exactly where the problem is. Is it with the guy? Is it with the woman? And if it's with the woman, where exactly in those structures is the problem? Is she not ovulating from her ovaries? Are the ovaries not ovulating regularly? Are the tubes blocked? In which case, the sperms are not meeting the eggs. Or is there a problem with the uterus? In other words, adenomyosis or fibroids and things like that. So treatment then is targeted towards what the problem is. So the first part of when we see patients is to identify what the problem is, pin that down. Once we know what the problem is, then we can then go straight to targeting that problem. But the one thing that is probably central to treatment is in vitro fertilization. So, which is IVF, which I'm sure, you know, most of your listeners will have heard about. So basically what it is the situation where you stimulate the ovaries, like I said about egg vitrification. You stimulate the ovaries to make eggs, you get those eggs out, you fertilize those eggs with the partner's sperms, and then you get embryos, and those embryos a few days later, or sometimes months later, are then put into the uterus of the woman, and then it's supported with hormones and expected to lead into pregnancy. So that's almost central to whatever the cause is, you know. So whichever the pathway that's leading to infertility is, poor sperms, tubal problems, ovarian problems, sometimes uterine problems, often an age. Often you find that IVF, you know, is a common level where people actually eventually end up, you know, with or end up doing because of whatever the problem might be. So it's one of the options. But along with IVF, there are a number of other things you can do. Intrauterine insemination, if everything else is fine and she's not ovulating, you can get her to ovulate. So there are a number of things you can do before you get to IVF, depending on what the problem is.
Right. So obviously all of these fit into the category of alternative reproduction technologies, do they?
Artificial reproductive technologies. Artificial.
Okay, so sorry, not alternative.
So ART, yeah. So that's all ART.
Obviously, ARTs are obviously they're well known, but I think the big question on everybody's mind would be the cost of these things, because we're like it's notoriously known for being very expensive, and
Yeah,
people sometimes sell an arm and a leg just to get pregnant, and then if it
yeah.
works the first time, and then if it doesn't, and then there's another time, you have to pay for all of this. So, what is a ballpark figure for what an IVF would cost like?
Yeah, so an IVF cycle, one IVF cycle, if you're based in Cape Town, will probably cost you anything from about 55 to 65,000 rands. In places like Durban and Johannesburg, it actually gets a bit more expensive, depending on the lab you go to. There are certain labs in Cape Town that do low budget IVF. So in other words, they don't stimulate you so heavily with the medication, and they aim at a low number of eggs, and they try and work that way. Target offers one of those, and you'll be able to get a really cheaper cycle there. Kruczewski also has an IVF lab where you can pay less than 50,000 to have an IVF cycle. So there are options, out there. But obviously, these places have to limit the intake of what they take, and they have, sort of to have a criteria for who comes in to have cycles done. And as in any government hospital, there's a waiting list, to have that done, and people, sometimes are impatient with that. In private practice, you can have the IVF cycle done whenever you're ready to have it done. And so that's a quicker process, So yeah, that's the ballpark figure as far as IVF is concerned. It's not cheap, but if you look at South Africa compared to the rest of the world, in actual fact, we are a little bit cheaper. So, places like the States and the UK, if you go and have a private IVF done in those places, you'll be paying sometimes up to perhaps even 3-4 times what you will be paying in South Africa. So, and even places like Australia. So that you're looking at sometimes you have people coming in from Europe to come and have the IVF cycles done here, and obviously combine it with a holiday because it's cheap.
That is quite smart. And I'm sure we know about those things, just obviously on lower ground level. Another question I want to ask is, how do we better make aware fertility issues amongst men and women so that we can facilitate a more open and sex positive conversation, and to move away from this shamefulness of not being fertile, not being able to fall pregnant or conceive?
It's a big problem. Unfortunately, in Africa, there is a stigma that is attached to people not conceiving or trying to conceive. In rural Africa, women get ostracized and maimed and sometimes even killed because of this. So it's a big, big problem. So that's a more difficult problem to tackle because it's rooted in beliefs that is handed over from generation to generation. People believe a woman must have kids, and she can have kids. There must be something wrong with her. She's either a witch or there's something wrong. So they have all those beliefs that are there, which, how do you change this? I suppose you got to start with trying to educate people. And it's a lot about education, which just tells them that there's nothing supernatural about what's going on. There is a reason why this woman is not conceiving, and there is treatment available to try and get to conceive. But part of that education is what I said earlier about mentioning the fact that 35% of cases is due to the fact that the male is the problem, or the male has an issue that they're not conceiving from. And, again, we need to bring that onto the table and say that men could be responsible, but there's also treatment that we could offer them. There's no reason to think that people are different from people that have kids. So it's about education around fertility. It's about sex education, like you mentioned. It's also taking that, that information or that education level to people at the level of secondary school, maybe, health talks, social media. You got to take it out there to make people understand that, these are things that happen. They are not alone. It's quite common. And there are things that can be done to help them. And then I guess on the other side of things will be what is offered to treat these people. And then I guess the government must come to the party. For instance, in South Africa, medically does not, they never do. Every patient that has IVF coming out of their pockets a lot of money to try and have IVF done. So, let's talk about medically coming to the party, but they haven't done that yet. And we talk about them coming to the party for years. It just hasn't happened. Yet we hope it might happen. At least the bigger medical aids perhaps would, allow that to happen. If that happens, then it'll be easier for the patient. And then maybe government in some way see infertility as a problem. Now, you can understand what's going on in Africa. The fact is, there are bigger problems. So there is issues with, TB, HIV, not to mention what we're dealing with the pandemic at the moment. But there's a lot of issues that are underlying in Africa, malnutrition, diarrhea, things like that, that the government, tries to focus on one way or the other. And fertility then takes a background, like a back step, back table. But it shouldn't actually be like that, because these women, like I said, are treated badly and they have a lot of issues in their communities. So, we have to get to a point where the government sees fertility as an issue and then maybe place some emphasis on that. So that again is talking and engaging with government parastatals and things like that to try and get those to come to the party as well. So it's very multifaceted to try and tackle this. But there's no one quick answer. You've got to try and approach it at different levels and see how it goes.
Yeah, thank you. That's a brilliant answer. Thank you so much. I'd like to move to birthing. Obviously, you're a gynecologist and obstetrician, right? Am I pronouncing it correctly?
Yeah, fair enough.
So obviously, you've helped lots of women through their pregnancies, and you've experienced, I'm not sure if you have experienced women who have gone through birthing trauma, postnatal depression. Has medicine found out why that happens? Like what causes those things? Or has science field ever discovered why that happens to a woman?
A number of reasons. Postnatal depression is common. So almost more than half, the women that deliver will have what we call postpartum blues, which is just for a few days, a week or something. And that's just related to a number of things. You've been pregnant, which is an imposition on your body for 9 months, your life is about to change completely in terms of how you knew it. There's now somebody else, to consider all the time. And this same person is not sleeping through the night, so you have a sleepless night. At the same time, society expects you to still function at work and expects you to function as a wife and perhaps a sister or a daughter. So those things don't change. You still have all that responsibility, but then you have this added responsibility all of a sudden, added to the fact that you might have had medical conditions while you were pregnant for which you've been treated for. So there's a number of reasons why there's a psychological toll on the woman that is having a kid. And so all that combined with the fact that there are hormonal changes as well. So there are lots of hormones that are very, very much higher than they were obviously outside pregnancy. That obviously has an effect on the mood of the woman as well. And then the social circumstances are still there. A lot of the women in Africa do not have the support of their partners when they have these kids that are left to them to deal with most of this on their own. So there are myriads of reasons why there's a psychological trauma on the woman that's just had a child. And so that's why postpartum depression is quite common. And I think the thing to say about that is, one is to identify the risk factors. So if a woman has already got an existing depressive illness or an existing psychological illness, she's at a much higher risk of having postnatal depression when she's pregnant and when she's delivered. So those women should be watched treatment, the sooner, whether it's just treatment with meeting with people and having, psychological talks or medication, for this. And then even women who do not have that background of depression beforehand, with everything that I've described, they also need to be able to seek help. So they need to understand that there's help available. There is a depression line. I don't know if it's related to naturally for postnatal depression, but there is a depression line available in South Africa that you can phone. So the thing for the woman to know is to watch out for those things, the excessive tearfulness, just feeling like you're incapacitated and you're not coping. Once you start having those sort of feelings, around the time when you just had a child, might be the time to pick up the phone and either speak to a psychologist or psychiatrist or phone that line and say, look, listen, I need a bit of help. And then people can come to the party and then talk to you. So again, it goes back to educating people to know and watch out for the signs. And it's not just the individual, it's the people around the individual as well. So in other words, the sister, the brother, the husband, the mom, the sister, you need to tell them, listen, they need to watch out for those signs of depression or change in mood or change in behavior, and then, sort of look for help early enough. So yes, it's a big problem. It's common, but there is help available, because if these women seek help and they are treated, they often cope better and they often do well after that.
Thank you very much. I'm not sure if you know that lots of people watch birthing videos on YouTube. I'm not sure if you know that. So what would you tell somebody who has watched all of these videos that show just a mess, some scary, painful looking mess? What would you tell somebody who's watched those videos and now are really scared of trying to conceive or even falling pregnant because they don't want to go through all of that pain? What would you tell someone who's watching those videos?
It's a tough one. I mean, the first thing is probably for them not to watch it, maybe. but I think what it is look, I mean, reproduction has been around for, thousands of years. And we're all here. So in other words, we've been doing this for so long, and women survive it. And they have, most women, by and large, 99% of women have a normal life afterwards. And I'm talking about normal sexual life, despite what looks like trauma to the vaginal area. So those are the figures, those are the facts. Having said that, we do know that, if you have a tear that is excessive or is not properly repaired, then you could have problems with pain and all that going forward as far as sexual intercourse and all that is concerned. So the thing to say to them is that it looks messy. It was, because there's going to be liquor, there's going to be sometimes feces and all that going on. So it does look messy, it doesn't look pretty. But by and large, most women recover fully. And if you have it done in a place where there's good medical help available, you should be able to function properly without any problems going forward from there. And you've got a little bundle of joy to look forward to afterwards. So,
yes, you do. I think I need to ask you about this, so-called stigma between giving birth naturally versus a C-section. Do you think, I don't know, is it a myth that, I don't know why some other women see other women as lesser for having a C-section versus cesarean versus natural birth? Why is that?
It's very much a myth. I mean, it's just people who are traditionalists or purists, so to say you have to have a child. There's no reason why that should be the case. The fact is that babies have gone bigger in the last 50 or 100 years. The pelvis has probably gone a bit narrower and smaller. So the incidence of cesarean sections is going to be higher because, it's just getting to a point where it's impossible for these big babies to come out through those sort of narrow pelvises. So that's what it is. But unfortunately, I hear what you're saying. There's a feeling out there among certain groups that if you're not having a normal kid, in other words, if you're not having a kid through the normal way, through the vagina, that you're less of a woman, that is absolutely ridiculous. So again, it's about educating these people that, it's not the woman's fault. It's not because she's weaker or she's a lesser of a person. It's just the fact that medically there's a reason why a cesarean section is necessary. And that's what it is. Yeah.
I think with that, another question I think women are faced with a lot is, or rather just, all females, discharge versus thrush and thrush versus discharge. And what is this discharge and is it natural? Are we supposed to be having it every day? And then the escalation to thrush. Could you tell us about that, please?
Sure. So, I mean, thrush is the commonest pathological kind of discharge that women have. But there's so many others. You could have vaginal discharge from so many other reasons. Trichomonas vaginalis, bacterial vaginosis, which is quite common as well, or just from the fact that, you're in different parts of your cycle. So there's a distinction between what we call physiological discharge and pathological discharge. So the bacterial vaginosis, the thrush, and those are all pathological. They're not normal. And the reason they're not normal is that the woman has discomfort with them. So there's either a bad smell that is not, pleasant, or it's a lot more, so it becomes a lot more copious, or it becomes itchy, leading to scratching and irritation in the vulval area. If that happens, it's definitely an abnormality and should be treated and treated early. A bit of a discharge happens on a daily basis because the vagina secretes cells during the course of the day. So, some women, and that varies obviously from woman to woman. So when we have more discharge than others, at the end of the day, a little bit of a stain on the panty that is not smelling, not irritating, that it just not, that's normal. A bit of wetness that has become dry during the day. That happens. So that even becomes worse around the time of ovulation. So the discharge is thinner and then obviously flows a bit more around the time of ovulation. So you'll have a bit more discharge. Obviously, if there's sexual stimulation during the course of the day, there's a lot more discharge as well. So there's a number of reasons why physiologically you would have a discharge. But the thing to watch out for is, as it becomes itchy, all of a sudden it's a different, all the time the discharge is there, but all of a sudden it's a change. Does it smell differently? Does it smell funny? Has it become itchy? Has it become a lot more than what you used to? If that happens, then you need to present. So thrush itself, just to say a word or two about that, is quite common. Women who are using antibiotics, sometimes just a change of environment and, around there makes a difference in terms of thrush. I mean, almost 1 in 3 women would have thrush at some point in their lives or the other. So it's very common. The problem is that people tend to misdiagnose it. Sometimes you walk into a GP's room or into a pharmaceutical company or a chemist rather, and they say to you have thrush. Just listen, you have a discharge of the thrush, you get treated for thrush. It's often overdiagnosed and treatment given, far too quickly for it. So what I'm trying to say is that there should be some caution in terms of how the diagnosis is made. And you might actually just need to see somebody who would tell you it's actually a thrush, this is something else, we should treat this. Or you don't actually have a problem, you're just going through a physiological phase and that will get better. But far too quickly people are treated for thrush. And maybe, something to be said for that is because it's quite common, and comes and goes, often in some women as well, especially around their periods. So the advice will be, women know their bodies. If you think there's something different, you would know. And that's when you should seek help. If it's a little bit of a discharge of wetness during the course of the day, then that usually isn't a problem. It's when it becomes copious, like a lot of it smelly or itchy, then there's time to look for help.
Sorry, this is my second last question, I promise. The hymen. I know that there's been a lot of stuff and stories and stuff around the hymen. And some people say that some people are born with hymen, some people aren't. The hymen is very different. What exactly is the hymen?
The hymen is just a piece of skin or membranous skin or tissue that is over the vaginal opening. And it's not always there. So it is right that some women are not born with a hymen. And a hymen is often got a hole in it, because that's where the menstruation happens from anyway. And that hole varies in size. So a hymen varies from completely being absent, not there at all, to just a tiny little pinhole in some women. So, that's the physiological nature of what the hymen is. It becomes a problem if there's no hole at all, what we call an imperforate hymen, and then the bleeding gets accumulated above the vagina. Sometimes we have to go and drain that. That sometimes happens. And to talk about the social side of things, some people say that you need to have a hymen to prove that you're a virgin. Now, that's not necessarily true. From what I've said already, that some women don't have it, and you might even have it, and the fact that you go horse riding often, or you're very active as a gymnast, you might have actually lost part of the hymen. Mm-hmm. If the woman has used tampons before, then the hymen also have been lost, by doing that. So it's definitely not a way to be sure that the woman is a virgin or not. It's just, one of those physiological things that people should be aware of and should have an open mind about.
So this is my very last question. I would love to have your opinion on sex education, not only in South Africa, but in Africa, the context, since you teach in various countries and you work in other countries as well. What is your perception on sex education in Africa? Like, is there any way we could somehow change the narrative and have it a more sex-positive sex education model? And what can we do more besides, you said earlier on about education and making people aware that biologically people are different and things happen? What can we do more so that we can have a generation one day that is open to talking about sex in a positive way and learning, and that it isn't this closed taboo thing that we can't speak about and it happens behind closed doors. That it's
no, you got a point. Yeah, it is a problem. It is a problem because, for most people in Africa, when you grow up, it's almost like a taboo to talk about sex. And I think that might be changing to a large extent already, definitely in some of the more modern schools where things are being discussed, and sex education is brought in a lot earlier than perhaps it used to be. But it needs to go beyond that. If you ask people when they got introduced into the idea about sex and reproduction, people have different stories. It's about birds and bees that their auntie told them about, or their mom told them, or their father told them about. It comes in different phases. So I guess we need to educate parents, we need to educate teachers, and tell the parents that you should have this discussion rather earlier than later. You can even say it's never too early to have the discussion, because you are just empowering these people with knowledge. It doesn't actually mean that you're going to make them any different from what they would have been. So it's about just empowering them with knowledge right at the beginning. And we got to use what we have, social media, podcasts like this, maybe television programs, and then reaching out to, I guess, I don't even know, maybe parent-teachers meetings, stuff like that, and just have those sort of discussions right at that level. Because the fact is that these young kids find out about sex in different ways. They're on the internet all the time, and they might even have a wrong perspective of what it should be like. So it's better to come from within, and rather than from without. So maybe we can also adjust what is being presented on social media or on the internet. That's obviously a lot more difficult. But maybe there should be sanctions as to what obviously there is an age limit to what young kids can watch. But that often doesn't always work. So it's a big pool out there. It's a difficult one. But the suggestions would be to go maybe to do more of what is being done already. Introduce the education discussion much earlier. Go into, sort of schools, especially in the rural areas. I think in the more affluent areas is not a problem so much as it used to be, but in rural areas, go and have that discussion on the first day of term, the assembly or something, have that discussion, and people, obviously that always, people get interested in it. And we just tell them what the real facts are and try and separate what the myths are from the facts and, give it to them as it is. And, we can't do too much. Whichever area you want to target, there will be some difference made, if one does that. So I guess my general advice will be just try and do as much as we can in all those spheres that I've mentioned. You know.
Thank you so much for your time. Thank you very much for the conversation that we have had today. And yeah, I just want to say again, thank you for joining us. And this episode will go live next Monday, the 28th. And I'll send you all the details, but thank you very much.
No problem. This is nice chatting to you. Take care.
You too. Thank you.
All right. Cheers.